Hello. Hello, everyone. I will just give our attendees a moment to come out of the waiting room and hop on. Good morning, Alicia.
Good morning. Good morning, everyone.
I still see people filtering in. Day 4, final day of the summit, coming across the finish line. All right. Hello and welcome, everyone. Thank you for joining us for day 4 of the 2024 Within Health Summit. Again, my name is Jamie Singletary. I am the Director of Clinical Brand Development for Within Health, and it is my pleasure to welcome you to the first CE presentation of the day, which will be held by my colleague, Alicia Cotner-Wilkins. She will be talking about ARFID, across the lifespan, strategies for treatment and support. Before we get into the presentation, I do just want to highlight a few housekeeping issues. Just want to remind everyone that this is a CE presentation, and in order to receive credit for the CE presentation, you will need to watch it live. You will not get credit for watching the recording, but you will get credit for watching it live. If there are any technical issues, I will provide the contact information for CE Go. If there are any questions about your CE certificate, I will also include my contact information. We will have the chat feature open, so I do encourage you to use the chat feature to share any questions, comments, or concerns that you may have during the presentation, and also an opportunity to connect with our presenter. So without further ado, I would love to read the bio for Alicia. Alicia Cotner-Wilkins is a licensed marriage and family therapist, certified eating disorder specialist and consultant, and a certified mindfulness instructor. Alicia has 25 years of experience in behavioral health, working with children, adolescents, adults, and families. She has focused most of her career on working exclusively with eating disorders and has held various clinical and leadership positions at all levels of care. She has been instrumental in launching eating disorder programs in Florida and Virginia. She has specialized training in cognitive behavioral therapy, dialectical behavioral therapy, family-based treatment, and mindfulness. She has provided supervision and training for those pursuing state licensure in addition to IADEP certification. She is the past president of the Richmond IADEP chapter, served on the IADEP National Board as a chapter representative in 2021, and volunteers with the Eating Disorder Coalition to support advocacy efforts. Additionally, she has presented at local and national conferences. Alicia is passionate about ensuring that clients have access to care and believes that full recovery is possible. She also enjoys educating and coaching family members and loved ones, as well as supervising and mentoring the next generation of eating disorder professionals. Ladies and gentlemen, I turn it over to Alicia Cotner-Wilkins.
Great. Thank you so much, Jamie, for that warm introduction, and welcome to all of you on our fourth and final day of the summit. So before we get started, because I know it has been a long week, just want everyone to take a moment. I guess this is where some of my mindfulness training comes into play. But I just want everyone to just kind of take a moment and just, as we settle into our first CE presentation of the day, just take a few deep breaths in and out. And I want you to think about, as you were getting prepared to come to this talk today on ARFID across the lifespan, what are you hoping to gain from today's presentation? If it's just CEs, I got you. There is nothing wrong with that. I know we all need our CEs. If it's something else, think about that, and there will be some opportunities for questions and answer at the end. All right. We are going to go ahead and get started. I was remarking to Jamie before I jumped into the talk this morning that this is the first time I have actually presented on ARFID at Within without my regular co-pilot, Catherine Williams, one of our senior RDs. So just a shout out to Catherine, wherever she might be today, and you are missed. This is a great opportunity, though, for me to highlight some of the treatment modalities that we have been able to put into place here at Within for our clients with ARFID. All right, let's go ahead and get started. And let's talk about how we're going to spend our time today. I just want to let you all know I have a much larger screen to the right as well, much easier for me to see. So you may see me glancing over this way periodically as well. So avoidant restrictive food intake disorder, we know that this affects individuals across the lifespan. Treatment strategies and interventions for ARFID have targeted children and adolescents, and information for adults remains limited. So, our presentation today will provide clinicians with an introduction to the diagnosis of ARFID across the lifespan, interventions for children and adolescents, and methods to modify these interventions for adults, not only at the outpatient level of care, but also at higher levels of care with a focus on remote settings. My other goal for today is to demonstrate how we continue to evolve our treatment for ARFID here at Within Health. So, if you attended our very first talk on ARFID back in December of 2022, and then we had two subsequently last year, and then today's presentation, hopefully you will see how we've been able to take some of the current research and learn from clients and learn from family members about what's working, what's not working, and how we have been able to get to the place with ARFID treatment that I'm going to present on today. And with some of the limited literature on the treatment of ARFID, although more continues to be forthcoming, in fact, I found three studies from 2024 for this presentation. We also want to share ideas, what's working, what's not working. This benefits all of us and it benefits our clients as we all work to treat this population, just reinforcing that point that it truly does take a village. So let's dive right in. We're going to first talk about the diagnostic view from the DSM-5 of ARFID. And this was not really a new diagnosis. It did replace the DSM-4 diagnosis of feeding disorder of early infancy or childhood. The DSM-5 did move the diagnosis from a feeding disorder to an eating disorder, and that did afford clients more treatment options, especially for those with ARFID. A few changes to note: the age of onset criterion was removed. It was previously limited to those under the age of 6. The weight loss criterion was also removed, providing a diagnostic framework for those with feeding disorders without low weight. Psychosocial stressors and physiological consequences were acknowledged, such as nutritional and medical deficiencies. And we do see sometimes nutritional deficiency due to a failure to one's failure to grow consistently as well. What you see in the top portion here as well we'll talk quite a bit about this today, are the three maintaining mechanisms of ARFID: apparent lack of interest in eating or food, avoidance of food based on sensory characteristics, and concern over aversive consequences of eating. Let's now talk about the epidemiology of ARFID. We know that between 5 and 14% of patients in a pediatric inpatient eating disorder program were diagnosed with ARFID, and as high as 22.5% of patients in a pediatric partial hospitalization program were also diagnosed with ARFID. What we see in some of the peer-reviewed journals and manuals, there's been a primary focus on ARFID in children and adolescents, and we'll share some of the limited research today when it comes to adults with a diagnosis of ARFID. In one setting, we saw 67% of clients with ARFID were male, and we generally see a 2-to-1 male to female ratio. In another study, between 20 and 30% of ARFID cases were male. In addition to some of the comorbid medical symptoms, we also want to highlight the comorbid psychiatric symptoms that we see. We know that children with autism are more likely to develop ARFID, and those with anxiety disorders are also at a higher risk of developing ARFID. More likely to have a history of picky eating, texture, or sensory aversions. Clients may also be responding to fears related to contamination, abdominal pain, seeing another person vomit or choke, or experience nausea or difficulty swallowing. Clients may be exhibiting some of those aforementioned maintaining mechanisms or somatic concerns really due to a variety of reasons. They may be reacting to stress, a past trauma. There may be fears related to contamination, maybe due to some of the messages that they're receiving from family members or out in society. They may restrict to avoid experiencing an aversive event again, and they may also restrict to avoid unwanted tastes or textures. Again, we also do not want to lose sight of the fact that clients with ARFID are also adults. And currently within our system here at Within Health, over 50% of the clients with ARFID that we currently treat are adults. So as we progress in today's talk, we'll share additional information about the presentation in adults over the next few slides. First, to set the stage here as well and to assist with our diagnostic framework, let's really take a look at the diagnosis of ARFID versus anorexia nervosa. So, some of the similarities that we see across both diagnoses are that eating in general causes stress and anxiety for both populations. Both diagnoses can have a rapid onset, although with ARFID, there's typically an earlier age of onset. Remember back to the previous feeding disorder diagnosis was for those younger than the age of 6. We also see high comorbidity rates. Clients with ARFID are less likely to endorse depression, whereas clients with anorexia are more likely to endorse depression. Both have medical and nutritional complications that may include fluid and electrolyte disturbances, nutritional deficiencies, gastrointestinal disturbances, and that can lead to hospitalization for both populations. So, what's different? As we know, ARFID clients are not concerned with weight gain, their low levels of shape or body image concerns. These clients often do not endorse depressive symptoms, substance use, suicidal ideation, self harm, or even purging or compulsive exercise. Clients with ARFID lack the cognitions around food, weight, and shape that we often see with anorexia nervosa as well. This is a great infographic that really highlights some of the similarities and differences that we see with ARFID in our pediatric population versus our adult population. Given that we see many adults with ARFID here at Within, it's important to socialize some of the similarities and some of the differing features of ARFID in both the pediatric and adult populations. This study came out in 2023, and it's one of the largest studies to date looking at the medical presentation primarily in adult clients with ARFID. In this study, most clients presented with fear of aversive consequences, as you see here in the middle, related to GI distress. We also saw that anxiety disorders were common. GI issues were the predominant medical comorbidity. Clients were also more likely to have low blood pressure and food and drug allergies, and low potassium was also common. Predominant psychiatric comorbidities across both samples was anxiety, followed by depression. And for adults, we did see a lower mental health quality of life. As we look at the comorbidities across the lifespan, it's also important to note that in these particular studies, the adults who presented for ARFID treatment did tend to be younger. Most were in their mid 20s, give or take. The prevalence that we see here with autism spectrum disorder and ADHD is also consistent, as you can see, with what we see in the adolescent population as well. For adolescents, what we see is that adolescents with bulimia nervosa typically have the highest rate of depression. Anxiety, as you can see clearly, tends to be higher in ARFID than with other eating disorders. And obsessive compulsive disorder does tend to be higher in anorexia nervosa. Those with ARFID also had a higher association with neurodevelopmental disorders. You can see there's pretty much consistency across both adults and adolescents. And the correlation between ARFID and substance use was low at 4.8%, although in another study, we've seen this number much higher, hovering around 20%. So let's talk a little bit about the assessment for ARFID and how we determine the diagnosis. So, first and foremost, as we would do for any other eating disorder diagnosis, especially here at Within Health, we would want to provide a thorough and comprehensive medical assessment, nutrition assessment, and mental health assessment. As Jamie mentioned, my background is as a therapist. So, in my role as a therapist, I would focus on providing a thorough biopsychosocial evaluation, taking into account the extent to which the avoidant or restrictive eating interferes with the client's activities of daily living, work, school, education, familial relationships. I'd also want to take a look at evaluating some of the co occurring disorders, such as anxiety, and the extent to which those are barriers to overcoming the avoidant and restrictive eating. The assessment would also take into consideration the maintaining mechanisms that we saw in the previous slide and any behaviors that might unintentionally reinforce the client's symptoms, such as familial and interpersonal relationships. For those younger clients, I would also want to provide a thorough assessment of the family, and even for our clients who are still living in the home setting. The family may unintentionally be providing accommodations, reinforcing the behavior, such as providing specific foods from specific grocery stores or restaurants that interfere with working to increase variety. I can certainly tell you that I have seen that across many clients with ARFID that I've worked with before. I've even had family members who have called restaurants ahead of time to ensure that the restaurant can accommodate some of the food preferences. I've also had clients travel to other countries and they have packed up some of the food preferences only to ensure that the chef at their destination will be able to accommodate some of those food preferences as well. For younger clients, we may also want to involve additional disciplines when the case is more severe or emotionally complex, or medically complex, I should say, or other specialists for more complex ARFID presentations. So we may involve a speech and language pathologist when we have oral sensory motor concerns. There may be difficulties with texture progression, swallowing, and that may make the process of exposures more difficult. So we certainly want to rule out any of those complications before we begin exposures. And we may also want to involve an occupational therapist, especially when there's difficulty processing sensory input, difficulties with activities of daily living, concerns around self regulation, and distress tolerance. One of the things in the DSM 5 that you saw in the previous slide was that the DSM 5 really highlights the marked interference with psychosocial functioning as one of the criterion for a diagnosis of ARFID. And some of that will vary on developmental age. When working with ARFID, we are reminded to consider concerns around psychosocial interference, as there may be instances in which some of this criteria may be primary. The client may already be meeting nutritional and energy needs, or may be of a normal weight as well. So the primary focus may become some of the psychological concerns. We see difficulties with participating in normal social activities, and that certainly becomes difficult for our adolescents. We know that there is a high correlation of generalized anxiety with ARFID. There may be isolation from friends and family due to a fear of eating in public. There may be difficulties maintaining a job, performing in school, friends and family, or difficulties establishing and maintaining relationships. Due to difficulties managing the eating situations, it becomes difficult to go out to restaurants, to grocery stores. And so much of what our young adults and teens do is with their friends is really centered around food and going out and sharing a meal together as well. The family may also be providing accommodations, reinforcing some of the safety behaviors, making familial relationships more strained, and it may also perpetuate low self esteem and confidence. I know from talking with a client not too long ago, one of the questions I asked about some of the treatment that they had had in regards to ARFID, and they did mention that, it did really strain their family relationship as well. So later on in today's presentation, we will talk about some of the supports that we offer for family members and loved ones here at Within. In addition to clinical assessment at the outset of treatment, we also want to supplement our evaluations with standardized measures as part of our measurement based care initiative. And I know you heard a little bit about some of that yesterday. I'm going to highlight some of the structured interviews that can be used for ARFID. Many of these do align with the DSM-5, so that's certainly helpful as you are trying to rule out other diagnoses as well. So one that we see is the eating disorder assessment for the DSM-5, the EDA-5. This is for adults and youth ages 8 to 14. It's designed to assist in the assessment of a feeding or eating disorder. The structured clinical interview also assists with diagnosing various comorbidities in addition to the eating disorder symptoms. The PICA ARFID rumination disorder interview is by far the most comprehensive, also quite lengthy. There are four versions of that. There's one for parents and caregivers for ages 2 to 3 year olds, one for ages 4 to 7, one version for children 8 to 13, and then a version for those 14 and above. The party assesses not only ARFID, but the severity and looks to rule out other eating disorders as well. There are also self report measures. One that we use here at Within is the 9 item Avoidant Restrictive Food Intake Disorder Screen. Yes, that is a mouthful, otherwise known as the NIAS. It is, even though it has the long title, it's very comprehensive. It only contains 9 items, also contains a severity assessment that looks at eating restrictions related to picky eating, poor appetite, and fear of aversive consequences. There's also a parent version of that assessment. We may also want to use the State Trait Anxiety Inventory, the STAI, and that also looks at anxiety traits and predisposition to anxiety, as we know that is also common in ARFID. This is, as I mentioned, the NIAS, and as I mentioned on the other slide, we use this at Within Health in addition to other eating disorder measures. As you can see here, there are only the 9 questions, and they are categorized very nicely to help individuals really flesh out the maintaining mechanisms of ARFID. As I also mentioned, there's also a severity assessment that looks at eating restrictions related to the picky eating, poor appetite, and fear of aversive consequences. So I'll give everyone just a minute to take a look at this as well. I can certainly make sure everyone gets a copy of this. It's also very easy to find on the internet. The other thing too that does become important as we move into treating ARFID is looking at the maintaining factors. And this is where the party assessment and other assessments that are designed to assist the multidisciplinary team in conceptualizing symptoms in this three-dimensional space that we see here. It's also helpful to conceptualize the case with the client and family when providing psychoeducation as well. We know that ARFID is an eating disorder associated with avoidance and restriction, and the maintaining factors over time promote avoidance and or restriction and may strengthen these responses without intervention. And we often see this in the lack of interest subtype. Limited volume can lead to more health issues over time, and selective eating may be maintained by disgust sensitivity. There may be negative predictions or thoughts around food that also reinforce some of the eating difficulties for the selective eating subtype. And lastly, for the fear of aversive consequences type, that often presents with physical problems such as physical or GI pain, abdominal pain, anxiety around a severe allergic reaction, worries around choking, vomiting, fear of contamination. And the fear of physical consequences reinforces the restriction, as does the fact that there has now been a decrease in the negative consequences when not eating, when avoiding or restricting food. And that just reinforces the ongoing avoidance and really perpetuates that cycle. So, treatment can be individualized to target these maintaining mechanisms. We often see an overlap between the subtypes. And one of the great resources, too, that really spells out different treatment protocols for these maintaining mechanisms is the CBT-AR manual. So, what does ARFID look like? Earlier this year, I had the opportunity to present or to attend, I should say, a 2-day conference on ARFID that was put on by UCSD. And what we see here are, again, the maintaining mechanisms of ARFID and some of the overlap that we see across the three subtypes. So, for the fear of eating, that is primarily under the food avoidance category. So, for the fear of eating subtype, we see specific fears, food allergies, triggering events, general anxiety around food, and avoidance of specific food. For the sensory sensitivity subtype, we start to see these symptoms straddle food avoidance and restrictive eating. We see general anxiety around food, avoidance of specific foods, use of nutritional supplements, picky eating, and sensitivity to tastes and textures. And then for the poor appetite, lack of interest subtype, here we see reduced portions, early satiety, abdominal pain, nausea, and gastrointestinal issues. So, how does ARFID work? I really love this model. This model highlights the general cognitive behavioral therapy model of ARFID. This is a tool that I share with parents and loved ones in our coaching program. It can also be used in therapy with clients for clients to really use this model to outline how does my ARFID work. It's also a great tool for teams to use for case conceptualization. The CBT-AR model starts with the premise that clients with ARFID are born with a biological predisposition leading to negative feelings and predictions about the consequences of eating, or there may be a food related trauma. And this in turn leads to food restriction or avoidance. So we may see a decrease in variety and or volume. And then if there are limited opportunities for exposure, that then reinforces the restriction, which over time may become chronic. So what we see over time is that without intervention, these factors reinforce restriction, resulting in a feedback loop. We can also use this model with the various maintaining mechanisms. So, for instance, for the sensory sensitivity subtype, The biological predisposition is that clients experience the sensory characteristics of food more intensely than most likely you and myself. With aversive consequences, there's a biological predisposition towards an anxious temperament or difficulties with experiencing bodily sensations. And then for those with the little to no interest in food, food is not experienced as pleasurable. So, as we continue to work with our targeted interventions, what we will work to change are the negative feelings and predictions about the consequences of eating. And by changing those thoughts over time due to exposures for new food and eating related situations, we will see progress with our clients. So let's talk about treatment for ARFID. I would be remiss if I did not highlight the pros and the cons of virtual treatment in general and for our clients with ARFID, because as we know, one of the hallmarks of Within Health is that we do provide effective treatment at home and we can provide effective treatment in the home setting for ARFID. And that includes our parents, our loved ones, and our supporters. One of the things that I remember working for a brick and mortar program in the early days of COVID was that because we were limited in the number of people we could have in the building, and that was usually the staff and the clients, was we really missed out, especially for our clients with ARFID, with providing family intervention as well. And so, what we did start doing was partnering with an in home agency in town. I live in Virginia, so that the agency was going into the home and really helping us to carry out some of the exposures that we needed or to help out with observing some of the contingencies or accommodations in the home setting that might also be reinforcing some of the behaviors. Because if we can intervene on those, we can certainly affect change in the moment. We also see as one of the benefits of virtual treatment is that food and other supplies are more readily available in the home. So exposures and problem solving can really take place in the moment and in real time. And another thing I was recently talking to a parent about as well is that virtual treatment may benefit our clients who may be immunocompromised due to low body weight as well. So, not having to go into a treatment facility where they are exposed to others who are out in the world, bringing in things that they have been exposed to can also be helpful to maintain their system as well. And as we know, some of the cons of virtual treatment are sometimes lack of privacy, especially for our clients with ARFID. One of the things that we see is there might unintentionally be some reinforcers in the home. So we may have a client on the screen who does not finish their food exposure or finish a meal. The behavior may be unintentionally reinforced, perhaps by a young sibling who runs into the room to give them a hug or to provide them with attention. Some of our clients do become distracted by their image on the screen, and so that may make it difficult to focus on the task at hand as well. So, just a couple of things I wanted to make sure to highlight today. Treatment at higher levels of care for ARFID. We know that intensive treatment is effective in reducing ARFID symptoms in adolescents. And the chosen intervention when it comes to the treatment of ARFID is typically going to be higher levels of care, and that does include our intensive programs, partial hospitalization, and intensive outpatient. Much of the research when it comes to treating ARFID at higher levels of care focuses on the pediatric population. Regardless, we do see the benefits of treatment in more intensive settings. Intensive treatment assists in reducing ARFID symptoms in adolescents. In fact, 79.2% of clients remained out of the hospital at a 2-year follow up following treatment at higher levels of care. And these were typically for the clients needing weight restoration. Hospitalization may be necessary prior to PHP, IOP, or any outpatient treatment for ARFID. Higher levels of care also offers clients and loved ones access to their multidisciplinary team for many needs, such as family therapy, nutrition and medical management, therapeutic meals, and group therapy, all under one roof. And there are also more opportunities for parents and loved ones at higher levels of care, such as separate skills groups, weekend planning sessions, family meals. There are also more consistent exposure opportunities. We'll talk a little bit about that. And due to some of the increased resources that we see at higher levels of care, this also affords providers the ability to utilize treatment accommodations to account for any comorbidities we may see with our clients. So, for instance, we may be able to build in frequent breaks into the programming day and work to create a sensory friendly environment in the client's home for meals and group sessions. So, again, not only the benefit of treatment at a higher level of care, but also another benefit of virtual treatment. So let's start to talk about some of the robust treatment options that we have available for ARFID here and that we are constantly continuing to expand upon. We are currently working to build out our core groups that are recommended for our clients with ARFID. Because we offer PHP Plus and IOP Plus here at Within, I'm sure you've heard quite a bit about that over the last 4 days. This really affords us the additional flexibility to be able to plug clients very intentionally into groups and meals. So, for a client needing weight restoration, they would not go to our ARFID table at first, but they would go to our support table to support increasing volume before we focus on increasing variety as well. Exposures in the ARFID table would be introduced when the client is at approximately 90% of ideal body weight for weight restoration. We also have a specific process group for our clients with ARFID, and that is led by one of our fabulous primary therapists, Brittany Ashmore. So, shout out to Brittany. I hope she is here today. We also have an exposure response prevention group, cognitive behavioral therapy. We have a really unique group called Working Your Nerves, and that incorporates polyvagal theory and some somatic elements, core nutrition for education, and DBT or RODBT skills group for increasing one's repertoire of skills. And then we also have a group called Emotion, and hopefully I can do a good job of explaining this group. This is a movement class that combines dance and yoga and repetitive and playful creative movement to support some of the somatic processes as well. That's a group that will be helpful for our clients needing more experience with body awareness as well. And we continue to expand on this as well. I'll share some of our ideas later down the road for future direction as well. With exposure therapy, this is an evidence based treatment modality to treat phobias, fears, and anxieties, which breaks the cycle of fear and gradually exposes the client to the fear in a controlled, monitored manner. So, this can involve sitting with the food all the way to eating the food. And so, for clients with the fear of aversive consequences driver, the fear hierarchy may be based on building up to the food or to the eating related situation. And we'll walk through that on the next slide. The therapist would play more of an active role when the exposure is not completely food related. We also want to use the subjective units of distress scale. We want to take the client's temperature. We want to take a look at how high is their anxiety before, during, and after an exposure, and what will assist with changing their temperature at the end of the exposure. Is it practicing distraction, singing, soft music in the background, for our younger clients, maybe holding on to a stuffed animal. And we can also utilize a dysfunctional thought record or an ABC worksheet as well to look at the before, during, and after to monitor the client's anxiety and emotion. So, going into an exposure, we might look at something along the lines of, what are you afraid will happen? How certain are you that X will happen? What is your SUDS rating? We then would engage in the exposure and then process afterwards what actually happened. And how certain are you that X will happen the next time, whether or not it happened at this time? And then get a final SUDS rating for the client. Also, during the exposure, we want to monitor for any safety behaviors. We want to look for any avoidance that we may see coming up in the moment. And that's an opportunity for us to, as clinicians, to target that and also provide some skills coaching around that. All right, so this is our current model for individualized support. I'm going to talk a little bit about some of the variability with this as well. Exposures will generally begin after the first week of treatment, again, unless weight restoration is needed. Exposures will start with foods in the 6 to 7 SUDS range. Clients will work on their food hierarchy with their dietitian. A new food will not be added until those foods in the 6 to 7 range decrease to 3 to 4 range. The goal during each exposure session will be 3 bites. However, the goals will be individualized per client. The recommendation will be to try a food about 20 times, depending again on the client in the individualized treatment plan. We also know it may take between 10 and 50 tries before a client adapts to a new food. We'll never do any more than 9 foods at any one time. The number of foods that we start with during exposures will depend on input from the multidisciplinary team. Certain comorbidities may require that we use one at a time, less steps, less directives. So, certainly, consultation among the multidisciplinary team will be paramount for this. We will also provide family or supportive therapy sessions to coach parents and loved ones on how to do exposures at the home. As you can see, we have a goal of doing one at home towards the end of the week. And as clients complete exposures, they will then bring the food exposed from the week before to programming meals. So, for instance, for partial hospitalization, that may be 3 times a week. And for intensive outpatient, that may be 2 times a week. This model from the CBTAR manual certainly emphasizes that this is indeed a process. When we are doing food exposures, we can start with these questions, the 5 steps, as a client works to approach a new food. This in and of itself is a sensory exposure exercise. We break the process down into sight, touch, smell, taste, and texture. This is also a model that we teach in coaching so that loved ones can assist with the exposures in the home setting. Research does note that the food must actually be tasted in order for the client to have an increased preference for that novel food item. And over time, eating a larger portion of the novel food as a part of one's meal or snack will assist with incorporating that food into one's repertoire. So, a couple of things to note here as well. As you can see here above, it says try to use neutral words without describing foods as good or bad. So, we want to move away from, as we do with other eating disorder diagnoses, describing food as good or bad, safe or unsafe. We want to avoid that black and white terminology. And when describing the food, we want to steer away from using any judgmental terms. We want to provide the facts. A helpful tool here is to perhaps teach the describe skill from DBT. And as we talked about previously, an exposure does not need to be just eating a food. It can be so many things and it can be broken down in so many different ways, and that will depend on the maintaining mechanism. So, for instance, if the driver is fear of aversive consequences, the hierarchy could be a hierarchy related to food contamination, choking, emetophobia. We can break this down into whatever steps we need to. And again, this is going to be individualized per the client. We may engage in other creative exposures, such as exposing clients to a video, perhaps related to the fear. So, this is just one example. And then I wanted to share a few examples of some of the different fear thermometers out there that we use when we are obtaining a SUDS rating. I've seen some clinicians that like to use a scale of 1 to 10. Perhaps for some of our more mature adult clients, we may want to use a scale of 0 to 100. If you just Google fear thermometer or SUDS rating tools, there are a variety out there as well. For some of our younger clients, they like these friendly emojis. That's certainly helpful for them when they are doing an exposure activity. All right. One of the things that I'm really excited to share with you all today is what we're doing in terms of providing support for our families and loved ones and some of the coaching that we have been able to institute here at within the last 6 months, as well as it pertains to ARFID. So, some of the support for parents, loved ones, and supporters, we want to involve them as quickly as possible on the front end of treatment, especially when it comes to some of the initial assessments, finding out if there are any food rules in the home, habits, practices in the family. Learning those things on the front end is going to go a long way. As I mentioned before, there are many benefits to being virtual, one being that parents and loved ones may play a significant role in daily exposures, management, coaching. This will also assist parents with the at home practice. So, for instance, depending on the developmental age of the client, we can teach parents creative ways to engage in exposures at home outside of programming time. So, for instance, for our younger clients, we may want to refer to exposures as food experiments. And maybe the client is asked to play the role of a food scientist and to consider each exposure with curiosity. We may want to look at implementing a reward system for each successful food exposure. So, what does that look like? The therapist would work with the family to establish a reward system for exposures, and a non food reward would be provided for each successful food exposure. Rewards would be of the parents' choosing. That might be additional time on electronics, TV time, although I don't know if kids really watch much TV anymore. I think everything's on electronics these days. So parents know their own kids the best, so they will know what types of reinforcers to apply. For older children and adolescents, one of the things when I worked in brick and mortar we had a point system for exposures as well, and we kept a little cart. Um, the clients could cash in their points at the end of the week for puzzles, toys, all sorts of trinkets as well. There'll also be some natural reinforcement. And then for young adults, a question I get often asked, especially if the young adult is not living in the home setting, what types of reinforcers can we use? So, one of the things that we do teach is the validation sequence. And that, in and of itself, can be a great reinforcer for some of our young adults. We also want to assist parents and loved ones with creating a positive mealtime environment that will help to increase positive behaviors. And we want to stay away from strategies that are deemed forced. In one of the studies, strategies deemed as forced were indicated as not helpful for adolescent and adult clients with ARFID. And so through coaching, one of the things that we also do is we provide family and loved ones with communication tools and DBT skills so they can also learn to manage their own distress because we know that they are an important part of this process. And learning to manage their own distress and frustration around this process will go a long way and keep them grounded. All right. So, how did we come to formulate the model that we use for our coaching? We looked at a few various coaching models out there. There were some studies readily available. One study that I want to highlight is the ARFID Parent Training Program, so the ARFID PTP. Um, in this study, they provided 2 2-hour sessions with an optional booster at the 4-week follow up. And they provided this condensed model as some of the models were really resource and time intensive, making it difficult for working parents and those with other children to attend. So for session one, they focused on ARFID psychoeducation, parental responses. So again, that communication piece and how parents respond to whether or not their loved one completes the meal, completes the exposure, mealtime hygiene, treatment approaches, skills coaching, and reward systems. And then session two focused on review and problem solving around skills from that session before, introducing the exposure protocol and the in session food exposure. And then 42.1% of the families requested the optional booster session. And the booster session really focused on continuing to increase parental confidence in their ability to carry out these tasks and interventions at home. There was also one other model that we took a look at, and that was called the SPACE ARFID model. That is a very long acronym. SPACE stands for Supportive Parenting for Anxious Childhood Emotions, and that provided 12 weekly 60-minute sessions. That model provided psychoeducation as well on ARFID, assessment of the family environment, looking at safety behaviors and accommodations, and then also focused on improving communication between parents, supporters, and their loved one. So, when it came time to formulate our coaching model, here is where we landed. We had to take into consideration several different things. The fact that we are operating in a remote virtual environment. We also operate across 4 time zones. We wanted to take a look at parent and loved one availability and time, as well as some of the topics that we were seeing loved ones frequently ask for as well. So we developed an 8-week coaching rotation, and that is led weekly by a therapist. That is myself, along with one of our fabulous registered dietitians. Shout out to Katie Cox. And psychoeducation focuses on utilizing evidence based treatment. So we cover CBTAR, DBT, and some of the ERP strategies. We also focus on distress tolerance. We teach mindfulness and emotional regulation and interpersonal effectiveness to our loved ones. But most importantly, it has really become a great space for parents and loved ones to share ideas with one another and to build their own community. And we do provide this service on Thursday evenings at 7 p.m. EST. It's currently only open to within health supporters. I'm just coming off of another successful evening of coaching. So one of my later slides has a brain dump of different ideas that the group offered last night. So really excited to share that down the road here. So, our coaching curriculum, as I mentioned, is an 8-week rotation. And in the first session, we focus on teaching the emotion, the EFFT validation sequence. And that's a hallmark of our family coaching in general. That supports clients and loved ones alike as they work to have greater awareness of what is happening in the process. And validation also affords loved ones the ability to best support their loved one in this process. Session 2, we focus on nutrition basics. So that covers meal planning, psychoeducation on the nutritional deficiencies that we see in ARFID, and the food preferences list. Session 3 is psychoeducation on ARFID, the diagnosis of ARFID itself, psychological concerns related to ARFID, and the goals of treatment for ARFID. In the next session, we jump back to nutrition and we cover mealtime skills and support. We review mealtime skills and the process for planning exposures. And the next session is psychoeducation on the maintaining mechanisms of ARFID. So we look at the various subtypes, the drivers of ARFID, and the basic ingredients for the treatment of ARFID. Distress tolerance, this is definitely a favorite of the parents and loved ones, and we utilize a DBT framework here to assist loved ones with developing their own repertoire of distress tolerance skills. Certainly really important, as they play an important role in this process as well. Then we look at exposures and the creation of a sensory environment. We discuss exposure intervention, the use of SUDS, food chaining, how to create a sensory environment in the home to assist with the completion of exposures. And then positive reinforcement, kind of going back to the slide we talked about before, looking at how can we implement a reward system in the home setting? Is that feasible? Does the family have the resources? Do they have the time to do something along those lines? And then one of the things that really is a common denominator across all of these 8 weeks is that throughout all the modules, we review the validation sequence and how communication is going. So that's something that at the start of every coaching session, we go back to and we talk about how is it going? What can we troubleshoot? What can we tweak? We know that from that model, we know that if loved ones are getting it right, and I say that with air quotes, about 30% of the time, they are already making a difference. So let's talk. You heard me talk a little bit about the sensory environment before, and I haven't had an opportunity to discuss that yet. But in one study, they looked at various adaptations for some of the various comorbidities. And it was suggested that various environmental adaptations are suggested, such as keeping the room where the exposures occur free of clutter or distractions, with the exception of perhaps some of the distraction tools or some of the sensory soothing aids. So, having it be an environment where you can sit down for the meal, you may need to remove pets from the room, those types of distractions. You might turn on soothing, enjoyable music. As I mentioned before, having some of those coping and soothing aids available. It might also be just, keeping the lights down. If the room is cluttered with a lot of furniture, removing some of the furniture, ensuring that colors in the room are less stimulating as well. And of course, one thing that we want to highlight is the don't yuck my yum. So of course, don't comment on my food as I am working through an exposure as well. Whoops, I hit the wrong button. Excuse me. Treatment adaptations as well. And, again, I would be remiss if I did not highlight this. We can also adapt treatment for those with co occurring disorders, such as neurodiversity or those needing to target weight restoration. So, adaptations may include frequent breaks in their schedule throughout the day. It may be shorter sessions. It may be the use of two-step directions. One of the beautiful things about our program is that we have groups and meals that start at 8 in the morning EST all the way up until approximately 10 EST. So for those clients that do need frequent breaks in their schedule, we can make that happen. Um, Clients may need less items during the exposure. As I talked about too, this is an individualized approach. They may need more time with each exposure. We may look to use visual cues, visuals of the SUDS ratings during meal times. I know that in our ARFID process group, Brittany uses animal metaphors or pictures to help clients identify what type of support they may need for that day or how they would like to be involved in the group. And we also use that at our ARFID table. So they can also use emojis to communicate their emotions at mealtime if they do get to a point of overstimulation. We can look at DBT adaptations, including modules around building a sensory toolkit for time of distress or any sensory overload. And that might take into account the client's level of hypersensitivity with each of the senses. And then the National Institute of Health and Care Excellence offers great guidelines on how to work with individuals with autism and those with eating disorders as well. And so some of these treatment adaptations I've taken from their literature. All right. And how do we support our clinical team as well? Not only do we support our clients and our loved ones, we also want to provide support for our clinical team, especially working with this population. So we have an ARFID task force. We meet regularly, and the task force has really been instrumental in helping to build out our ARFID program as well. It's also been a great opportunity to pull together our multidisciplinary team and representatives from each of our disciplines, as they all play a very important role in this treatment process. It's helped to build an effective ARFID program in a virtual space where we also take into account not only research, but also feedback that we receive from clients and loved ones, also those with lived experiences. There's some great websites and social media pages out there that detail the lives of clients with lived experiences and what is working for them and what hasn't worked. We also provide exposure training. We also have a staff meeting, AKA our treatment team, and that's a time for us to discuss case conceptualization, to also flesh out the maintaining mechanisms of the disorder for treatment planning purposes. We also use our time in staff meeting to discuss goals for the next week, including any upcoming exposures, progress on current exposures, and to process what has been helpful and what has not been helpful more recently. And then our wonderful care partners, our CPs, they are also valuable members of the team. They have the primary responsibility of supporting clients at our ARFID table. And as I mentioned before, that is a space carved out for our clients with ARFID to have meals and to build that community as well. So, future directions, where do we go from here? I have to be honest, I had a few things on this slide last night, and coaching just kind of turned into this opportunity to discuss things that, maybe we could work on implementing in the future. And as I got to work on this slide, the creative juices just kept flowing. I probably could end up talking on this one 2 hours. So it was fitting that we had coaching last night and generated some of these additional ideas, and it delved into additional program offerings that would be helpful for clients and loved ones alike. So where do we go from here? Right after this, today, you're going to hear Jamie and the alumni team talk about some of the alumni offerings that we have here at Within Health. We currently do not have an ARFID alumni group, but certainly something that we would love to delve into in the future as well. Um, we could move in the direction of over time. You saw earlier that we have the emotion group, but we also could put into place a body awareness type of group for our clients, whether that's in the form of yoga or, maybe something a little bit more fun for our clients. We could also have a specific skills group for our RFID clients. As you all know, we're utilizing the NIAS. We can also look at implementing additional outcome measures as well to look at barriers and future progress. We could have a specific relapse prevention group. We do offer a multifamily group on Tuesday evenings at, I believe it's 7 or 8 p.m. We could also have a specific multifamily group for those with ARFID. We also have an anxiety management group on our current schedule, but we could also have one that is specific and dedicated to those with ARFID as well. And then one of the ideas that one of the parents brought up in the group last night was that it would be helpful to have either a guest speaker, someone with a lived experience, or someone who has graduated from within as a treatment complete. So we could have a guest speaker either come to the parent coaching group or come to one of the other groups that we currently have, whether it's the ARFID process or another forum as well. So many, many ideas. So if you come back next year, hopefully I'll present at the summit again, and maybe we will have some of these things in place and probably a whole other wish list of things that we certainly want to add into our programming here as well. So fortunately, we have time for a case study. I feel like every time we present, we do not ever have time to get to a case study. So we are going to have time for one case study today, and then we will move on to question and answer. Okay. So this client is a 34-year-old female who presented to Within Health after spending 2 weeks inpatient and 8 weeks at residential. The client was experiencing severe abdominal pain, which impacted the client's ability to eat many foods and adequate portions. This client's weight had declined to 65% IBW prior to going inpatient. And through inpatient and residential, the client's weight did increase to 95% of ideal body weight. But this client's intake was a little bit more than 50% from supplements and no experience with exposure to foods. So I would love to hear from you all if you all would love to chat in what you might do in this case. Whoops. Give everyone a minute. Anyone have any thoughts? Trying to get my there we go. Having trouble with my toolbar. Oh. Jamie, I may need your help. My toolbar has
Yes,
disappeared.
I am here. We do have a comment. It said, could you clarify if the client's abdominal pain was at the start of their PHP or residential or inpatient?
Okay, it was at the start of their inpatient. Thank you.
And then there's another question saying, how do you calculate the ideal body weight?
Ooh, that is a good question. So that would be based on, this is why I need my dietitian here. That would be based on many different things, height, weight history. why my chat keeps disappearing.
You can't see the chat.
No. I move my cursor up and it disappears.
Someone says the BAW clinically, HAMWI formula.
Mm-hmm.
Don't body weight. Another comment says, were they continuing to experience the abdominal pain at the start of the PHP?
Yes. I guess I picked a tricky one with the GI stuff.
Tricky is good. Someone is asking, was there family or peer support?
Yes, I will talk about that in a second, actually. Yes, very much so. All right, well, great questions, everyone. Given the GI presentation too, our initial assessment involved medical, specialized medical due to the GI distress. We did not have a lot of information around that when the client first came to us from the inpatient and residential. So, of course, we provided thorough and comprehensive nutrition and medical and therapeutic assessments. Nutrition focused on building the hierarchy of food exposures and slowly engaging exposures due to some of the client's GI discomfort once medical cleared them. We did have to rule out some of the other issues prior to starting the food exposures. So, at least from my vantage point, I was actually this client's therapist. Treatment also involved looking at how my ARFID works. We saw that much earlier in the presentation today, and how the client's thoughts also reinforced the restriction and avoidance. And we really worked to target some of the thinking patterns. Treatment also involved family therapy. We did not have our coaching at that time, but there was 1 to 2 times a week family therapy. One of the client's siblings participated in treatment to assist and my role was to assist the client's loved one with looking at how, because they did spend a lot of time together, how the eating disorder may have been accommodated and how the loved one could be supportive in this process. So I really have to commend the sibling for coming up with lots and lots of creative interventions to assist with exposures. And then over time, the client was able to, once some of those foods were incorporated into the repertoire, was actually then able to go out into a restaurant setting as well and practice some of those foods too. And the sibling was really supportive. We worked a lot on their communication processes. So much of the family therapy really focused on communication among the two, validation, and reinforcement for completion as well. Um, and suffice that to say, the client successfully treated treatment at within, stepped down to IOP after a course of partial hospitalization with us, and then intensive outpatient afforded the client the ability to practice more exposures outside of the treatment setting. So, as I mentioned before, going out to restaurants, doing different exposures, even going to things like music festivals where there were food trucks as well. So we were able to get really, really creative here as well. And then the client successfully went on to outpatient treatment as well. All right, I want to open up to questions. One thing I want to draw, if I can get my chat to work, I want to drop one thing I often get asked for is, oh, my chat is not working again.
What do you want to put in? Maybe I can help you.
Just wanted to put in the workbook. I wonder if I stop sharing, if that will help. Here, let me just end this for a second. Okay. That is just weird. I can't get it still. All right, well, let's turn it over to questions and answers then. I also have one thing I want to note too is we can get the I wanted to share with everyone there is a free CBT-AR workbook as well, where a lot of the infographics that I use in coaching, you can get some of those as well. So I wanted to share that too. And then I also have a 4-page resource list too. So if anyone is interested in that, um, if you want to just drop your email in the chat as well, I can certainly get that information out to you today.
You do have a question, Alicia. One of the attendees wants to know, here at Within, are we seeing any patterns in our clients that are coming in with ARFID as it pertains to a particular age group or any demographic? Are there any similarities with our ARFID clients?
Yeah, that's a great question. There was a time where, as I mentioned, more than 50% of the clients that we have with ARFID are adults. There was a time where about 9 out of 10 of them were adults as well. One of the similarities that we do see when it comes to the maintaining mechanisms is we tend to see more of the sensory sensitivity type, as well as the little to no interest in food subtype as well. And then, of course, as we saw in many of the slides, we do see a high correlation, mostly with anxiety as well.
Do you find that the parental involvement in ARFID looks different than traditional family involvement with eating disorders?
Yes, because the parents and the loved ones are helping to do a lot of the exposures in the home setting. So, yes, we do target some things such as communication and validation and skills, but we're also focused on really using them as a really important part of the treatment team, to assist with some of the exposures in the home setting, because that just continues to, as you saw in one of the slides, it might take between 10 and 50 tries for a food to become part of the client's repertoire. So that does, kind of force our hand to use the parents as a resource as well. But one of the great things about providing treatment for ARFID, especially at a PHP level of care, one thing to note is we can provide PHP 5, 6, or 7 days a week, and then intensive outpatient we can do 3, 4, or 5 days a week. So the number of days also allows us to modify the days and the times that we're doing the exposures. So we build a lot of momentum with the exposures as well.
Speaking of exposures, that is the next question. Are you
Okay.
able to provide examples of exposures that we would give a client, perhaps that they can do with the family and maybe on their own if they're going back to school?
That's great. So let's say, for instance, let's say one of the foods is eggs that they don't like to. So part of, the food chaining as well, that's certainly a great place to start. Um, Maybe a client doesn't like something that is a red food. So maybe it's a red lollipop to a red pepper. But what we can do with exposures is, if they don't like eggs, for instance, the exposure might be looking at different ways that we make the egg. I do remember doing an egg exposure with a client when I worked in brick and mortar, and they had different types of eggs on their plate. And then over time, as they became more accustomed to the food and we started to see their suds go down a little bit, then we added in spices. So there's many, many different ways that you can do food exposures as well.
A lot of our attendees are asking for those resources.
Okay,
So we'll make sure and we'll put your email in the chat so that they can email you too if you want to.
perfect. Perfect. That's great. That's great.
Back to the family support, a question here is asking, are there any particular groups that you feel work well with the families, meaning having clients present or having clients separate, and how do we do that at Within?
So we currently have a couple of groups that we offer where the families do attend along with the client. One is the multifamily group, and one is the DBT for clients and parents. So those on my future directions slide, that is something, as our ARFID population increases here, that we would like to add into our repertoire of groups and supports that we offer for clients. So having a separate multifamily group and having perhaps maybe not necessarily DBT focused, but a skills group for parents and loved ones. Because right now it's the separate family and loved one coaching and friends and the separate groups for clients, but we don't have anything that overlaps. So that would be something that we can offer down the road as well.
And as it pertains to meal support, are ARFID clients in meal support with other clients at Within that have anorexia or bulimia diagnosis?
So the ARFID clients have their separate ARFID table, and the clients with the diagnosis of ARFID are together. If they are at the support table, that is for clients needing a little bit more support, or when it comes to our clients with ARFID, our clients that need weight restoration, they would be mixed with other diagnoses. However, when they hit that 90% ideal body weight, give or take, they would then move over to the ARFID table where they would be with other clients with ARFID, because it's very individualized as well. So we want them to be with their specific cohort. Many of them already know one another from the ARFID process group as well. So we really encourage our clients with ARFID, if it works in their schedule, to participate in the process group as well, because they will encounter one another at the ARFID table. Great questions, everyone, on day 4.
I know. And we actually have another question, and this is regarding length of stay. Do you
Mhm.
find that ARFID clients stay longer in our program or a shorter duration, or is it about the same?
That's a great question. I don't have any exact statistics on that. I would say it's most likely about the same. The one client I did the case study on, I want to say was here about a good 9 months. About a good 9 months. But I would say on average, PHP probably about 2 to 3 months, IOP probably about 3 months. Great
I
question. And hopefully next year I will have some more information for you all on that.
These were excellent questions. I do not see any more in the chat or on our question box. So with that being said, thank you so much, Alicia, for a wonderful presentation. And for those of you that are remaining with us throughout the last day of the 2024 Within Health Summit, we appreciate your time and attendance. We will break in just a moment and we will pick up with a conversation about alumni programming and how amazing our alumni care team is. And we will actually hear from one of our former clients who is now an alumni who will be sharing some amazing information and details around their experience. And we will also wrap up today with a final presentation from Dr. Wendy Oliver Pyatt. So again, thank you all, and we will see you shortly. Have a wonderful day. Thank you,
Thank
Alicia.
you all, everybody. Have a wonderful weekend.